Now, when we see patients with varicose veins, what happens is we still take a step, everything heads north to the heart, but when we relax, some blood comes over from the arterial side, but some blood falls back down because now we have incompetent valves along the saphenofemoral junction and within the superficial system. So this prevents the blood from moving only in one direction, and it actually moves in a retrograde fashion, filling these veins. The increase in volume results in an increase in pressure. The veins dilate, they become tortuous, and we see the classic presentation of varicose veins. Now, the worst case scenario is where we have not only incompetent superficial valves, but we now have incompetence of the perforator valves and maybe some level of obstruction within the deep system, some sort of latent chronic DVT that we don't know about. So what happens is we take a step and some blood goes up, some blood goes out the incompetent perforator, some goes down the incompetent deep system, and when we relax, you can see some blood flows down, some comes in, and it's all this very circular motion of flow, so we can't empty the calf properly. We never reduce that volume and that pressure, and it sets us up for what can eventually become chronic venous insufficiency with ulceration. So in the ultrasound departments or vascular labs, our job is to detect chronic venous insufficiency in these patients. When we evaluate for venous insufficiency, we have to figure out what kind of pathology is involved. Is it strictly reflux? Is there some DVT present? Is it a combination of both? And what anatomy is involved? Is it the superficial, deep, perforating veins, proximal, distal? All those questions have to be answered by ultrasound. Again, here's a patient with a venous stasis ulcer, and you can see the marked pigmentation and the varicosities in their leg. Now, a complete protocol will involve all three areas. Sometimes clinicians have seen the patient before, they know what's going on, and they can focus you in on a particular segment. But in terms of the deep system, we'll evaluate for DVT, as well as look for reflux within the common femoral and popliteal veins. We don't usually include the tibial level veins because there's really not too much that can be done for those vessels in terms of correcting that valvular incompetence, so many people choose not to scan those. We also look at the superficial system, but there we really need to evaluate the entire length of the great and small saphenous veins, and also perforating veins. And in this kind of a patient here, many of the perforators involved will be in the region of the ulcer. This ultrasound image just shows a normal venous flow profile. We can see flow and then no flow. We see tiny little bit of retrograde flow here, and that's normal because as flow comes up towards the heart, the valves open, and we need just a little bit of back pressure to engage and close those valves. So this tiny little bit of amount must be less than half a second, and that's normal valve closure phenomenon. In this example here, we can see this portion of the flow profile is actually retrograde flow. We can see we're angled up towards the heart, so flow's moving in this direction, back down the leg. It's going to present a positive Doppler shift, and that's what we see here. This is about a 4-second sweep total, so this is about 2.5 seconds worth of reflux. As I said, with the deep system, we're going to look through the whole femoral vein, stopping and taking images along the way. We want to see flow and then no flow. This is a little bit of augmentation, no retrograde flow, so that's a nice competent femoral vein. We continue all the way down. We can use our color to help guide us, particularly in the deeper vessels. And again, though we want to confirm what's going on with our spectral Doppler. The last level of the deep system, as I mentioned, would be the popliteal vein, and we can see that here. The popliteal vein, again, nice normal phasic flow with no retrograde flow. Now I put in this slide to remind us that we really need to adjust the equipment with reflux studies. We really want to set the Doppler scale, or PRF, such that when we augment, we produce aliasing, as illustrated here. And then after we produce that augmentation, we see this long, low level, low venous Doppler flow profile here, which is indicative of reflux. Sometimes these velocities are very, very low, so we really need to adjust the system appropriately. Now, some folks use just manual compression, squeezing the limb in order to augment flow, pushing that flow past the transducer, waiting, listening, and looking. However, some folks don't like that. And years ago, Dr. Paul Van Bemelen, when he was at the University of Washington, published this paper which said, well, you know, squeezing is good, but let's try to standardize it. So he said, let's put some various cuffs on the limb, inflate them to certain pressures, greater pressures as we move distally in the leg to account for that hydrostatic pressure, which increases distally. Let's inflate the pressure and then rapidly deflate it and look and listen. So this is a standardized way to augment and look for reflux. Some folks do this and find that it works very well for them. Now, what about the superficial system? That's really what clinically we can see a lot of varicose veins in these patients. We'll start at the saphenofemoral junction, which is illustrated here. Here's the great saphenous vein emptying into the common femoral vein. Color-coded in blue, flow is going all the way back up towards the heart. So that's normal antegrade flow. In this slide here, we see two examples. We have the patient Valsalva, which is obviously something that some folks have difficulty with. So it's important before you start your venous examination to have them practice doing that Valsalva maneuver. We have them Valsalva. We see virtually no color flow, just a little blip here, but this is a competent saphenofemoral junction. As compared to this example on the lower right, we have them Valsalva and we see the orange reddish color here, which is indicating flow towards the transducer, which is reflux. Color is great and color can rapidly identify reflux, but I would recommend that we actually still do spectral Doppler as well, putting in our spectrum and looking at and being able to measure the reflux time. All the equipment can do this. In this example, our reflux time is almost 3 seconds. Most folks have gotten away with trying to grade severity of reflux, saying that maybe a half a second to 1 second is mild, and then 1 to 2 is moderate, and greater than 2 is severe. Pretty much nobody uses those kind of systems anymore. And in general, folks use a half a second of reflux as being significant. Some folks will use 1 second, particularly in the deep system.